Hi, my name is Dr. Mary Jane Hogan. I'm an associate professor in pediatric hematology oncology at Yale, and I'm going to be talking about blood and neoplastic disorders in children. Today's lecture modules will include my approach to anemias, hemolytic anemias, and hemoglobinopathies. We'll start each module with a question. A healthy 3-year-old is a picky eater and drinks 32 ounces of cow's milk daily. She appears pale without other physical abnormalities. Which of the following blood test results support your diagnosis? Is it A, low total iron binding capacity, B, microcytic anemia, C, low haptoglobin, D, elevated ferritin, or E, macrocytic anemia? The correct answer is B, microcytic anemia. The child in this vignette consumes a diet low in iron. Iron deficiency anemia manifests with small or microcytic red blood cells. The incorrect answer, A, high total iron binding capacity, is indicative deficiency, whereas in this scenario, it was low total iron binding capacity. The incorrect answer, C, low haptoglobin, is indicative of hemolytic anemia, typically presenting with jaundice, unlike this vignette. The incorrect answer, D, elevated ferritin, is seen in inflammation. Low ferritin is seen in iron deficiency. And the incorrect answer, E, macrocytic anemia, is associated with vitamin B12 deficiency. And cow's milk contains a lot of B12. The definition of anemia is pretty standard. It can be either a low red cell mass, or what we like to use in hematology, 2 standard deviations below age-dependent and sex-dependent hemoglobin concentration. So look up your values for the appropriate age of the child. Hemoglobin is a direct measure of oxygen carrying capacity. It measures the concentration of hemoglobin in whole blood, whereas the hematocrit is a calculated value, so is not as accurate as hemoglobin. So in hematology, we like to refer to hemoglobin as our measurement of red blood cells. When you are approaching a child with anemia, you want to get a great history. And children with anemia have symptoms that vary. It varies with the age of the child, as well as the chronicity of the anemia itself. When anemia occurs acutely, the symptoms are more severe, whereas when anemia occurs chronically, there's a gradual compensation in the body, and thus the symptoms seem less severe. We also like to consider what is the cause of the anemia. So let's go over the different ages. All ages will present with pallor, high heart rate, feeling tired or irritable. Infants will often have a feeding intolerance, meaning they won't breastfeed or formula feed very well. They'll sweat with the feed. They'll be very irritable. Children who are older will experience dizziness and body aches, but sometimes it's difficult for them to explain that to their parent or even to you. Teens will have exercise intolerance, shortness of breath, headaches. They'll feel cold. They'll have ringing in their ears, and sometimes they'll even have syncope. Sometimes we approach the anemia by the different causes as well. So if a person might have hemolysis, they might present with tea-colored urine, which is literally the bilirubin in the urine. They'll have scleral icterus or jaundice. In the newborn period, you may have a setup for a red blood cell antigen incompatibility, whether it be the A, B, O, Rh, or minor antigens. Or a newborn might have an abnormal newborn hemoglobinopathy screen. So please be mindful of that, and we'll talk about that later. In children or teens, they may, before they have anemia, may have a prior infection. They may have had a transfusion. They may have had a chemical exposure, such as mothballs or fava beans, as seen in glucose 6-phosphate dehydrogenase deficiency. Or you also want to ask about a family history of gallstones or enlarged spleen or splenectomy. If you're considering blood loss as a possible cause of anemia, in the newborn, you'll have to ask questions in your history about placental abruption, fetal-maternal transfusions, or recurrent phlebotomies. When you're asking child or teen, you'll have to ask about gastrointestinal blood loss, nosebleeds, how heavy are their menstruation, any blood in the urine, or coughing up blood, any blood in the lungs. And when you're considering possible decreased production as a cause, you will have to ask these questions as well. What is the child eating? Are they taking appropriate amounts of iron, B12, folate? Are they taking excessive amounts of cow milk, or are they eating foreign substances as in pica? Is there any history of acute or chronic inflammation? Any recent infections? Does a person have an underlying autoimmune disease or chronic organ dysfunction? Medications exposures are very important as well. Ask about recent antibiotics, anticonvulsants, as well as chemotherapy. Lead exposure is not as common as it used to be, but it can still be found. Lead can still be found in old paints, in dirt from leaded gasoline, And also ask about family history. Are there any anemias? Most families don't know that there was a thalassemia trait in their family. They'll just say, I've always had anemia. Also ask if anybody in the family has ever had any transfusions. Moving on, after you've gotten a thorough history, you'll want to do a complete exam. And signs of anemia on exam include tachycardia, tachypnea, hypotension, and growth delay. You want to take a look at the skin. Is it pale? Look at the eyes, the nail beds, the palms. Is there any jaundice or scleral icterus? Is there any glossitis, nail spooning, or hair loss? On the chest, you want to make sure there's no cardiac murmur or gallop or any wheezing. The abdominal exam, make sure there's no hepatosplenomegaly or masses in the abdomen, such as from renal anomalies or tumors. And check the extremities. Make sure that all the bones are there. There are no radial limb anomalies or short stature. This is a photo of glossitis. You can see this tongue on the left here is very smooth and it's missing a lot of papilla. This is often found in B12 or iron deficiency. And on the right, you'll see the abnormal texture of the nails. This can be due to iron deficiency. As hematologists, we like to classify anemias based on some of the lab results we get, including from the complete blood count. And so we will classify anemias due to low production when we see a low reticulocyte count. We'll classify it as increased destruction when we see a high reticulocyte count. And when there are losses, blood losses, there might be a low or a high retic count. Sometimes we'll base it on the morphology that we see, whether it be the red cell indices, such as mean corpuscular volume, which indicates the red blood cell size. We look at the red cell distribution width, which will let us know the spectrum of sizes of the red cells, and we'll take a look at the peripheral blood smear. So in issues where there is decreased production causing the anemia, we always think about the nutritional intake. If it's down, whether they're anorexic or have a poor nutritious diet, or whether there are increased demands on the body for the nutrients, such as in growth spurts or after heavy menstruation. Decreased production can also be a sign of marrow failure, whether it's acquired or congenital. It could be a sign of marrow infiltration by cancers or metabolic diseases. It could be a sign of systemic illness, as seen in acute or chronic inflammation, such as autoimmune disease, thyroid disease, or even kidney disease. When we're considering blood loss, is this due to injury from excessive phlebotomy or hemorrhage? And when we think of anemia due to increased destruction, we split it out into immune-mediated hemolysis or mechanical shearing, or actually inherited defects in the red cell membrane, the red cell enzymes, or in the red cell hemoglobin synthesis. So morphologically, the top smear of peripheral blood here shows normal size red blood cells with normal color. The very small dots are platelets, and the white blood cell there you see are neutrophils. On the lower left, microcytic anemia as defined by low MCV. You'll see that the red cells are smaller than the lymphocytes that's in this picture. In this picture here, you'll also see that there is decreased color or hypochromasia of the red cells. And on the right, macrocytic anemia, where the MCV is high, the red cells are larger and often don't have central pallor at all. And we'll discuss that in a moment. So, microcytic anemia, what are the causes of this? Well, iron deficiency is one of the most common causes in the United States. It is seen in 10% of children. It's usually due to poor nutrition, whether that be from excess cow milk ingestion, chronic blood losses. Premature infants also are iron deficient because, as you know, as a baby, you get most of your iron stores from the 3rd trimester of pregnancy. And if the mom is iron deficient, the baby will also have low iron. Or if the baby is born before complete gestation, full-term gestation, then the baby will have low iron stores. Lead poisoning can occur, whether it be because of pica, where the child is iron deficient and is seeking other sources of iron, so therefore eats paint chips or dirt. As I said, you could see this in old homes as well. If a child has alpha or beta thalassemia traits, hemoglobin C trait, hemoglobin E trait, or even hemoglobin H disease, these are small red blood cells. There's an increased incident in children with African and Mediterranean or Asian ancestry, and those are questions you can ask during the history, although not everybody knows their ancestry. Anemia of chronic disease or inflammation, whether it be acute or chronic, can cause small red blood cells. So to sort of look at or decide what the diagnosis is, you're always going to see a low hemoglobin, a low MCV. The RDW may be high or low in microcytic anemias. The retic count may be high or low in microcytic anemias. When you check your smear, maybe you'll see target cells, as you would see in the thalassemia traits. If you see hypochromasia, you might see that with iron deficiency. A poikilocytosis can be seen with anemia of inflammation or iron deficiency, or even a red cell membrane disorder. And microcytosis is a definition of a low MCV. So other tests that you might want to get include iron studies, which is serum iron, total iron binding capacity, serum ferritin. You might want to get a serum lead level, as well as hemoglobin electrophoresis, and a C-reactive protein would help you analyze for inflammation. If you suspect blood loss, you might want to get stool samples for blood. And of course, you could always test the parents as well. Or you literally would have to ask the parent to go to their physician to get a CBC and retic count obtained if they haven't in a while. Because iron deficiency is the most common type of anemia in this country, often pediatricians will get a point of care hemoglobin. If they see some mild anemia, they will start a trial of oral iron, of course after obtaining a great history and physical, and then they'll have the child return after a whole month of iron supplementation, as well as good dietary advice to see if the anemia has resolved. If it has not, we suggest referral to a hematologist. However, the pediatrician could also evaluate for causes of microcytic anemia. Macrocytic anemia. There are many different causes, the most common being megaloblastic due to either B12 or folate deficiency, or due to drugs that interfere with a folate metabolism. Marrow failure is often seen with a low reticulocyte count. These conditions are more rare and should certainly be suspected if there are other blood counts that are low or there are other congenital anomalies. We will discuss later Diamond-Blackfan, aplastic anemias, as well as Fanconi anemia. Myelodysplastic syndrome is mostly seen in adults, but sometimes we can see in children this condition where the bone marrow can't make appropriately red blood cells, white blood cells, or platelets. And sometimes the first cell line that's down is the red blood cell. These are often seen in syndromes. Other causes of macrocytic anemia, it's commonly seen in normal newborn CBCs. If you have reticulocytosis due to a hemolytic anemia or recovery from blood loss, reticulocytes are immature red blood cells that are very large, and so that'll skew the MCV to being elevated. Liver disease also makes the red cells large. Hypothyroidism. Those children with trisomy 21 will have high MCVs, as well as medications will do it. Medications unrelated to B12 or folate deficiency. So the diagnosis of macrocytic anemias include obviously a low hemoglobin, a high MCV, the RDW may be high or low, and the reticulocyte count may be high or low. The smear might show a variety of red blood cell sizes and shapes. Polychromasia indicates that there are some reticulocytes or more bluish appearing red blood cells. As you remember, reticulocytes still have some nuclear material which makes them appear blue under the microscope. Hypersegmented neutrophils are often seen in B12 deficiency. Other tests that you might want to get, besides your CBC and retic, include a serum B12 level, a methylmalonic acid level, and homocysteine. These help to diagnose B12 and folate deficiency. Often you cannot rely on the B12 level or folate level because these are falsely elevated just from having a meal right before the blood test that has some B12 or folate in it, and it will not reflect the actual stores in the body. Hemoglobin electrophoresis can be obtained looking for hemoglobin variants that have large red blood cells. Liver function tests are very important because of the history, because of the possible cause of liver disease. And sometimes, if there are other congenital anomalies or other cell counts down, or the macrocytic anemia is persistent and continues to rise, we will do bone marrow testing. There is a familial macrocytic anemia as well, so sometimes we do check the parents to see if they have underlying large red blood cells. These people are very healthy. It's just something they've inherited and will pass on to their children. This is a slide here to sort of differentiate between B12 and folate deficiency. As you know, B12 is found in meats, chicken, fish, eggs, cheese, and folate's found in green vegetables and cereals. B12 deficiency and folate are typically due to malabsorption. Those who are vegan will not eat meats, chicken, fish, or eggs, so they need to supplement with fortified yeasts. And pernicious anemia is a condition where there are antibodies to intrinsic factors produced in the gut, and therefore there's no lack of transport of the B12 to the body. In folate deficiency, this might be on the boards or not, those children who infants who exclusively consume goat milk will have folate deficiency. So it's very important to ask about dietary history, both of these. For B12 deficiency, the onset is slow, and that is because B12 stores last for about a year in the body before you realize that you're very low. Whereas folate deficiency happens rapidly over months because our folate stores are lower and we use them more frequently. Signs and symptoms of these are quite similar. However, in B12 deficiency, you will have eventual neuropathy if the B12 deficiency is occurring over a long period of time, whereas in folate deficiency, there's no neuropathy. As I mentioned before, you want to check a B12 level, which would be low in B12 deficiency, and there would be a high methylmalonic acid level. This is a precursor to cobalamin or B12, and when B12 is lost, you can't metabolize methylmalonic acid, so this value will be high. And in folate deficiency, you'll have a high homocysteine level because you cannot metabolize homocysteine without folate. Treatment for both, it can be oral or injections, but make sure that you treat a person who has B12 and or folate deficiency with both B vitamins because you don't want to mask a deficiency of one over the other by replacing the only one of the two deficiencies. Often these do occur simultaneously, especially if there is a poor diet or malabsorption. So normocytic anemia, that means that the MCV is normal, and yet there's still anemia. Causes include acute or chronic blood loss, acute or chronic hemolysis, acute or chronic inflammation, and as well as something called transient erythroblastopenia childhood, which I'll discuss in our next module on transient acquired red cell aplasia. The diagnosis of normocytic anemia, you'll have a low hemoglobin, a high or normal red cell distribution width, and a normal MCV. In general, you'll have normal iron studies, but if you have a high ferritin, that may be an indication of chronic inflammation or disease. The reticulocyte count is very important in normocytic anemia. If it's low, you might have anemia of chronic disease, transient erythroblastopenia childhood, acute blood loss, acute inflammation, cancer, malnourishment, liver or thyroid disease. Whereas if the reticulocytes increased, you might have congenital or acquired hemolysis.